Welcome to All Things Cardio-Oncology. My name is Steve Casella. I'm the Executive Director of ICOS, and in this podcast, you'll hear from a diverse representation from within our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, today it's a pleasure to welcome, as usual, my co-host, Dr. Arjun Ghosh. Arjun, live from London. Welcome.
Thanks so much, Steve. Pleasure to be here.
And Dr. Dan Lenahan. Dan, coming from St. Louis. We appreciate you being on today as well. Thanks.
Thanks, Steve and Arjun. Always look forward to these conversations.
Well, over the past few years, one of the things that we've been really excited about as an organization is the formation of different working groups. And it's a pleasure to welcome members of our pharmacy working group today. Welcome to Heather Moore. Heather's a PharmD working in clinical oncology as a clinical oncology pharmacist in breast oncology at Duke University Medical Center. Welcome, Heather.
Hi, Steve. Thanks for having me.
And Craig Beavers, also PharmD, is Assistant Professor of Pharmacy Science at the University of Kentucky. So welcome, Craig.
Welcome. Happy to be here.
Well, we have the perfect cardio-oncology team with us today. Craig has a specialty in cardiology, Heather in oncology. So this is exactly what we look for in these conversations. Well, as we begin, I wonder if Heather and Craig, you could each tell us just a little bit about your background generally, your career path, and how you developed your interest in cardio-oncology. Heather, how did you get to where you are today?
Yeah, so I did my undergrad in biology at NC State and then went to pharmacy school at UNC. And that's when I first developed an interest in oncology. And then from there, I did residency. I did my general residency at the Durham VA and then my oncology residency at VCU in Richmond. And from there, that's where, originally thought I was going to do heme malignancies, but then had a real interest in solid tumor. And then that's how I ended up in breast cancer, which I've really come to love because I really enjoy the complexity of our regimens and we just have really great patients. But that's essentially what led me to cardio-oncology as well, because we do have so many therapies that are cardiotoxic, thinking about HER2 therapies in addition to anthracyclines, and then even our more targeted therapies, thinking like ribociclib, which is a CDK4/6 inhibitor. So I think just oncology in general, you see so many toxicities that have to be managed, but especially within this subset within the breast cancer patients. And that's really where I just kind of fell in love with toxicity management and trying to make drugs fit patients and manage these patients so they can maintain therapy.
Thanks for sharing that background. Yeah, you're never going to run out of opportunities for new learning. That's for sure. Craig, tell us a little bit about your background and how you ended up in cardio-oncology.
Yeah. So my journey mimics Heather's in the sense that, I did an undergrad program at the University of Kentucky. Clearly my institutions are different. Unlike Heather, I have less variability though. I did pharmacy school at the University of Kentucky and graduated there with my Doctor of Pharmacy degree. And like Heather, pursued additional training. I did my PGY1 or my postgraduate year one also at the University of Kentucky or with UK Healthcare, and then my PGY2 in cardiology at UK Healthcare. And over the course of the years, my focus in my career has been primarily related to in and outpatient cardiology management through a variety of different disease states. And managed a lot of heart failure based populations. So like Heather, I think, seeing the patients that have these kind of, traditional cardiotoxicities, but really I got a deep interest in this because I've been the chair of the American College of Cardiology's cardiovascular team section. And obviously cardio-oncology is becoming more and more kind of well-known and profound of a great field. And so I have gotten engaged in how do we understand and train our clinicians, both pharmacists and non-pharmacists, to be prepared to take on these roles, especially as, we have a lot of people who trained in when cardio-oncology wasn't an official pathway. And then on top of that, just having seen other instances where I can seem that my cardiology peers need additional guidance in this area. So I think that's how I've really jumped into this and how we set up the processes in clinics and work together with our heme and hematology oncology folks to better the care for our patients.
Thanks, Craig. It's always helpful to hear kind of how people got to where they are and particularly their background interest in this field. Heather, you're the chair of the International Cardio-Oncology Society's Pharmacy Working Group. Tell us just a little bit about that group and some of the projects that you all are working on.
Yeah, so just as Craig alluded to, so the biggest project that we've been working on over the last year or so has really been to gauge and have a better understanding of cardio-oncology, and specifically thinking about pharmacists as well as other healthcare providers, as we acknowledge that there is certainly a gap and that it is a newer field. So we did a survey that initially started with oncology pharmacist as well as cardiology pharmacist to have a better understanding of exposure, background, education, interactions, how these pharmacists are managing or involved with patient care, specifically with cardio-oncology. And then we expanded that to other healthcare providers, including APPs as well as physicians, in addition to some of our nurses as well. And that helps us just give a better understanding of, where we are and where we need to go. And from there, our goal is to identify gaps and how we can move forward. I think additionally, it gives us some insight on how we can better train and think about programs for future pharmacists and specifically cardio-oncology specialties. And then more so, how can we better treat patients and provide resources within both the inpatient and clinic setting, specifically for cardio-oncology needs. So I think that's probably been our biggest project over the last year. And then we're hoping to present that at GCOP here shortly, and then we'll write that up as a manuscript, and then we'll go on to next steps. We've also utilized some of that information to better tailor our webinars in terms of what may be helpful from an education standpoint for healthcare providers, and kind of utilize some of that as well. So that's what we've been working on so far. I'm excited for our results and how we can better shape the field.
Arjun, what questions do you have for our guests?
Thanks, Steve. So really interesting to hear from Heather and Craig as to what the working group is doing. Lots of exciting stuff there for sure. I think a lot of our listeners are always keen to understand the clinical aspects of all the different speakers we have on the podcast. So maybe I could turn to that. So if I could ask both of you, what is the role of the pharmacist in the cardio-oncology team, and how do you interact with your oncology and cardiology colleagues? Because, pharmacology is a big area, of course, in cardio-oncology. So maybe, Craig, if I could start with you.
Yeah, sure. And I'm sure Heather will echo this, because overall, generally, as pharmacists, we're working through thinking about, the holistic aspects of the patient and comprehensive medication therapy management in the context. And then obviously we take it to the next level based on our specialty. And so, kind of my role is, cardiology diseases and disease state management and the pharmacotherapy related to that. And so I'm often interacting in both my clinic setting and in the inpatient setting with my cardiovascular team. And, really their focus is on the cardiovascular disease patient, and I'm paying attention to that piece, but the other medications and things that are occurring with them. And oftentimes, on the inpatient side, they may not know that they're on chemotherapy or what, where they're at in their course of the regimen and what that entails for our treatment, for that disease state. Or could their reason they're being admitted be related to this item? I think of a great example of a patient we had admitted that was getting treated with 5-FU, and they did a very high dose rapid treatment, and clearly the next day or so came in with kind of chest pain, angina symptoms, and I was the one that was able to identify very quickly that, by the way, while we're in the process of working, I want to put this out there that this could be the reason that we're admitted here, and just kind of working through that, and then identifying as we work through the patient and work them out, what are the next steps we need to do. And then likewise in our clinic setting, kind of doing those same processes where we're working with our hematology oncology peers as we identify things, whether it be, their to Heather's point, she'll probably allude to this. They're beginning to manage a patient who is beginning their breast cancer journey, and they're working with our cardiovascular team to screen them, reduce the risk, and those activities. And I'm helping optimize their treatment, get them on the right treatment plan or dose and management, and then helping streamline their regimen so that it's successful and they're adherent and taking those things and educating it from that standpoint. So really, it's all things that you can think about from a medication perspective. But clearly, I'm thinking about, okay, for example, my hematology oncology team wants to use this regimen. What do I need to do to allow them to optimize this, or not have to stop it, or do something different if we need to do those things from that standpoint? And so, I'll let Heather add some color and layers to it.
Yeah, I would agree with that. And I think something that Craig alluded to that is a great point is that with both cardiology and oncology team members and pharmacists, I think you really get the perspective of both cardiology, oncology, as well as inpatient, outpatient. And I think that's also where our roles can sometimes be a little bit different. So I am in the breast cancer clinic. And so in terms of what is more so consistent with my role as a clinical pharmacist, and specifically in the cardio-oncology sector, is identifying patients that may be at high risk prior to starting chemotherapy or targeted therapies, and helping to get those patients into our cardio-oncology team so that we can optimize them prior to chemotherapy start. And then also helping to manage those patients, and then just thinking about general toxicity management. So I think that's where our big focus is not only prevention, but also monitoring those patients through chemotherapy, how we can best do that, and then how do we manage and monitor those patients after, and then especially thinking about our metastatic patients that are on lifelong therapies, and managing those patients. I think something that we've touched on a little bit, but not to the full extent yet, is that within the oncology sector and thinking about cardiology management as well, especially with many of the antiarrhythmic agents, is that there are so many drug interactions, and we do have so many targeted therapies. So we do have to be very mindful of drug interactions, dose modifications, drug monitoring, drug management. And I think that's where it is really helpful to have a clinical pharmacist that can identify that up front and determine when do we need to modify which agent that we're going to use to treat what, in order to make sure that we're not interfering with their cancer therapy as well. And I think that as we continue just in general, within our healthcare system, multidisciplinary teams have become essential to really manage these very complex patients. We have patients that are, post-heart transplant, patients that have multiple comorbidities, patients that, in the setting of all of those things are now getting chemotherapy. And you really have to be mindful of not only your drugs and what you're doing, but also their concurrent medications and therapies to ensure that you're treating them in the safest way possible, and really managing them to the best of your ability. So I think that's kind of like the tip of the iceberg, but just a few things that we think about as being key clinical roles.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, that's really interesting to hear what the day job is like for both of you. And one of the things that we learned quite quickly in cardio-oncology is that we need to talk as cardiologists to oncologists. And of course, we have the oncologists coming to talk to us about the patients. So is this something that you would see yourselves, or do you already do this? I mean, Craig, do you talk to your oncology pharmacist counterpart? And Heather, do you do the same?
I definitely do in these scenarios, and I think Heather's in a great practice, and I'll let her talk about it, where there's maybe a lot of integration there that is already occurring, and I know that's an evolution that is happening. But and we do in our practice. But I know there's instances where even in our non-traditional cardio-oncology clinic practice setting, for example, our inpatient setting, that, I've had instances where we've, God love my cardiologist, and especially my interventional cardiologist, they will, their immediate focus a lot of times in emergency is, putting stents in people to help them in, an emergent chest pain or stimming setting. But then we find out after we've stented them that, they're on this agent, this chemotherapy agent, whatever it may be. It could be a TKI, whatever, and then it's like, oh, by the way, hey, now that we've done this, we've got to think about the fact that we have committed them to dual antiplatelet therapy. And so we need to either figure out what our length and duration of that's going to be, or if we need to change the chemotherapy regimen. And so, that's where I, find time to dialogue with the hematology oncology team and the pharmacist, be like, okay, here is where we are at, and where do we want to go the next steps? And we have to do it together, because, at what point do you say, at this point, the most important thing is that we need to maintain their chemotherapy, or vice versa, and that's having that conversation and getting the perspective of, where the patient is at from, in their journey of their care, and saying that at this point, the risk is highest with this versus this point. So I don't know, Heather, what are your thoughts?
Yeah, I would agree. So I would say that we certainly are in touch with our cardiologist, and with our clinical cardio-oncology team. I think that as the field evolves, that there will be more connection between the groups. I think right now, while we do have, specifically thinking from the pharmacy side, some involvement with our cardiology pharmacist, I would say within our institution, we probably have a larger inpatient cardiology focus. And while there is some interest there and some engagement, it does seem to be more so in the outpatient setting. But I think that that's something that we, identify as a gap, that we do need to have more presence, more interaction between both the cardiology and the oncology teams as this field continues to evolve. So I think it does help to identify what our, current barriers are. How do we move past those? Because I do think it is essential that we do work together. I think Craig brings up a great point that, from our standpoint and from the oncology side, we're very much focused on how do we treat their cancer, how do we maintain their therapies, and that's really our big focus. So, while we're monitoring, for instance, for HER2 therapy in metastatic patients, we're not doing echoes every 3 months, because as long as those patients are asymptomatic and stable, we want to make sure that we're continuing their HER2 therapy in this setting to maintain stable disease. Versus in the more, acute settings, and thinking about the cardiology side, I think sometimes it's a very different perspective that is also important. We just don't think of as much because we're so focused on the cancer and the oncology side of things. So I think if anything, it does help us to realize and see that moving forward, we do need to have more interaction between these two sectors as our therapies continue to develop, as we're using more targeted therapies and we're using agents that do cause more cardiotoxicity. And it's not like your standard cardiomyopathy that you're seeing from anthracyclines. So I think it's
just to your point, Heather, like another great example, and we use this a lot. Actually, we've used it in some of our webinars we've had. And if you ever want to go back and watch them, you can. AFib is a great example of there are diverse ways to resolve and solve AFib in all aspects of it, whether it be, using catheter ablation or antiarrhythmic therapy, or, even thinking about the anticoagulation piece. And that's where it really is helpful to come together, because it's like, okay, here are our options. What chemotherapy you're on, here's what we can do to avoid those things. If it recurs, it really highlights how you have to have those bidirectional conversations of what we're going to do for the patient. And it's one of those tricky disease states that, AFib can be treated successfully or can recur regularly. It's a tricky disease state that is never, it's not like, okay, we got their hypertension under control. I'm not saying hypertension isn't, but like it's one of those things that is always an interesting thing to deal with. But
sure. And I think really interesting to see that obviously those kind of interactions between the two teams already happening, and more is required. So that's really great to hear. And I suppose my last question will be, and I think, Heather just touched upon this, that, there's always new drugs coming out, exciting drugs in the oncology space. How can a simple cardiologist keep on track with all of these new oncology drugs that can potentially cause cardiotoxicity, Heather? So if you have any kind of, hints or tips for us.
I think this is where I put in my plug for Cardio-Oncology Pharmacist. And so I think that every day there are new FDA indications or new therapies being developed. I literally checked my email earlier and there were 3 new FDA approvals for therapies today in the oncology sector alone. So I think it's something that's just an ever evolving field. It's very difficult to keep up with new therapies, targeted agents, monoclonal antibodies, antibody drug conjugates. They're just so readily becoming approved by the FDA and going into utilization that it's really tough for oncologists to manage them. That's why we have such, subspecialties now, because it is very tough just from a general oncology perspective. I think if you have resources and accessibility to an oncology pharmacist or, a cardiology pharmacist or someone who's involved in cardio-oncology, that's certainly, one of the best resources to have. But if not, I think when I think about resources that are available, there are quite a few, thinking about specifically cardiotoxicity. I know that HOPA and ENCODA have drug resources available for cardiotoxicity and some of the ways to manage those and being more mindful of updated oncology therapies. So I think that that's a pretty good resource. There are multiple databases and sources that you can look through that give you a general idea of what cardiotoxicities you may see with certain therapies. I think the other thing is just being very mindful of drug interactions and concomitant therapies. I think that's probably something that we struggle with quite a bit, that I know that I'm heavily involved in. So those are certainly some resources that I would think of. Craig, do you have any thoughts?
Yeah, no, it's funny because I reflect on your comment about the explosion, if you will, of agents in the oncology space, and for sure we definitely feel that pain and keep up with it. And I don't know, to Heather's point, that's why there's so much subspecialization. It blows my mind about the oncology approvals, but I think where it is different in the value of being with a cardiology pharmacist and or a cardiovascular team, and Arjan can maybe attest this or appreciate it, but if you run into a situation like I alluded to earlier, where you have that patient who needs some form of antiplatelet therapy or dual antiplatelet therapy, and they're also on an agent for their chemotherapy bleeding, we are in the thing that has changed rapidly and continues to evolve is the whole construct of managing a patient with stents and in the dual antiplatelet therapy and how we manage that. That's where our explosion of literature is. That if Heather learned in her PGY1 that we do DAP for 12 months, well, kind of like asterisks beside that, we have so much data to say to do differently, and that's where we work as a partner, because Heather doesn't know the depth and breadth of all that data, but that's where myself and Arjan and the cardiologist and be like, okay, don't worry, we can work around this a little bit more than we used to, right, Arjan? So
yeah, great. So that's very, very interesting. But I think great pitch maybe to have your own cardio-oncology pharmacist. I think that's a great point. I'll hand over now to Dan.
Thanks, Arjun. Yeah, I think mainly I would say the 2 biggest questions that exist, and certainly in my mind, in relation to having a pharmacist engaged fully into the team, is availability. And then how do we train future people? Those are the 2 biggest questions, because at various institutions that have been in the past, having a pharmacist as part of our cardio-oncology team is very difficult to make that happen. And, obviously, in Heather and Craig's case, they were made available. But, how do we make that available to more places, number one? And then number 2, when you have trainees that are interested in cardio-oncology, how do we get them, to sort of lead the way?
That's a great question. And that's something that I think a lot of institutions have struggled with. I know even within our institution, I mean, I work with our cardio-oncology team, but I'm also the breast cancer pharmacist, and that's my primary role. So I think that that's something that we continue to struggle with. And I think that's one of the reasons that we started working on the survey and getting a better gauge of where we are and where we need to go. And I think that that's something that's become very clear, that from a resource standpoint, we just don't have it available for the majority of institutions and providers that are there. So I think one is identifying that there is a need, which is what we're working on, and then how do we impact that need? And I think that is really just showing how can you essentially prove that you have benefit with a clinical oncology or cardio-oncology or cardiology pharmacist within that sector. And I think that's showing the benefit that they have within the team. And I think there's some literature there, but not as much as we would like. And that's what we're working on. But I would say for those that may not have specifically a cardio-oncology pharmacist, if you at least having a resource in terms of a clinical oncology pharmacist or cardiology pharmacist or clinical pharmacist that can provide some insight that may be interested in being involved. That's why we have our working group within ICOS, and our goal is to expand resources. But I think first, if you don't have someone that is very subspecialized in this area, it would be involving your clinical pharmacist. They're well trained in terms of drug interactions and can provide really great resources and help with some of the complexities of certain things that can be helpful. But I think really the big answer is just growing the field. You determine a need and then you work on filling it. So that's kind of where we are in the setting of things.
Yeah, so I think that this is really great. I do think that this is an important issue to struggle with at each place, and whether it's a big institution or a practice, finding ways to have active participation from pharmacy with all of these complex medication changes is really absolutely necessary. And I think that the biggest thing is to really just keep putting it out there and figuring out how do we influence administrations to support these endeavors. And the bottom line is that it's all about improving patient care. So we're
and to your point, and I'm sure Heather would echo this. That's the great thing about ICOS and working together with our work group, and we would love to have people engaged. But the nice thing is we have a great team of people that are in diverse settings and areas that, if you need mentorship or ask questions or how did we get there or how do we, quote unquote, build this plane together, we most certainly can help, people navigate those things, whether it be a pharmacist trying to figure it out, or if we have our peers that are in the organization that are coming to us saying, I'm a cardiologist or I'm an oncologist, excuse me, and I would love to have a pharmacist in my clinic. What can I do, or how can I get to that point or sell it? I think that's where, hopefully as we get more sophisticated, we can do that. But even in the current moment, we can talk through and mentor and connect to people. Heather, your thoughts on that?
Yeah, I would completely agree. I think the biggest struggle right now is just identifying how we can grow the field and then implement pharmacists within this area. And I think you made a lot of great points in terms of how do we integrate this into residency training? How do we make pharmacists more available? And I think as this area continues to grow, that is something that we will see in terms of residency training. And the question is, do we add another year? Do we add in more rotations? But training, providing the additional training for those pharmacists so that we can have more resources to be available, because I think right now it is very limited, but would agree with pretty much all that you said in terms of availability.
Heather, if I could jump in and just ask, are there any, two questions. Are there any medications on the horizon, new classes of drugs that you're really excited about as an oncologist? And then have you seen greater attention to the development of therapies that are safer from a cardiac perspective?
Those are both really great questions. I would say in terms of therapies for oncology, I always get excited about these. Right now, and you've probably heard because it's gotten so many FDA approvals and indications literally in the last 2 weeks, But in HER2 or trastuzumab deruxtecan is an antibody drug conjugate. It was previously utilized in HER2 positive breast cancer patients in the metastatic setting, but now has evolved into other cancer types and is now being utilized in HER2 low. So a couple of things about that. So one, the drug itself is fairly novel in that it's an antibody drug conjugate. It's a very potent therapy. I think it in itself is probably leading the way for drug development moving forward in terms of having these more complex targeted therapies that are not only efficacious, but we're seeing them highly utilized in multiple different sectors within oncology, which I think is incredibly exciting. And then to get to your other point and kind of growing upon some of that, the more complex our therapies are, the more that we do see that they are more toxic. And as we, are utilizing them more commonly in not only like in this instance, metastatic patients, but maybe sometimes in early stage patients, or we're broadening the indication and how we're using them, we need to be more aware and more trained in terms of how are we going to manage and monitor the toxicities that are associated with them. So, going back to my example with HER2, specifically it's a HER2 targeted therapy, so it does have a risk of cardiotoxicity. But I think really the important part is how do we better monitor these patients, manage these patients. And so I wouldn't say that necessarily the cardiotoxicity is limiting the development of new therapies. I do think that in general, it is providing a bigger focus for monitoring. So again, I always say we need to find a way to make drugs fit patients and not patients fit drugs. So I think it's how do we prepare these patients, identifying patients that may benefit from prophylaxis upfront or getting them into cardio-oncology prior to starting therapy so we can better optimize their outcomes and we're not seeing the cardiotoxicity that's associated with them. Another good example, specifically in the breast setting, again, I'm a breast pharmacist, is ribociclib, which is a CDK4/6 inhibitor that causes, QTc prolongation. And that's something that we're monitoring. And, right now, one of the big discussions is, previously it was a contraindication to include patients with any cardiac history or concern for cardiac history prior, and how do we fit that in? So now we're trying to identify, well, which patients actually do we determine to be contraindicated here, and how can we broaden the use, because this particular therapy has been shown to be perhaps more efficacious than the other drugs within that class. So I think it's really identifying patients that may be at higher risk. How do we, reduce that risk for them? How do we keep them on therapy? And what is the best way to monitor them so that we can continue this therapy, especially when they're having response? So there's a few things that I personally am excited about as oncology continues to grow.
Well, thanks so much. This, I feel like we say this at the end of every episode, but just illustrates again the incredible complexity of working in this field and the necessity of collaboration across disciplines. So thank you both for your time. Dan and Arjun, thank you for your time. Appreciate all of you being a part of this episode. For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.